Good morning, everyone. Welcome to this meeting of West Yorkshire Joint Health Scrutiny Committee on the 16th of July 2025. The first item of the day is appointment of Chair and Deputy Chair for this municipal year. Could I possibly have a nomination, please, for the Chair?
I'd like to nominate Councillor Smage as Chair. She's held that post for a number of years and I think has acquitted herself extremely well in it.
Thank you. Do I have somebody who can second that, please? Thank you. Thank you, Councillor Scott. Can we have a show of hands if everybody's in agreement for that, please? Thank you very much. So Councillor Smage is appointed as Chair. Can we now move to Deputy Chair? Could we have a nomination, please, for the Deputy Chair for this municipal year?
I nominate Councillor Hutchinson.
Thank you, Councillor Jamil. Do we have somebody to second that, please?
I second that.
Thank you, Councillor Lay. So we have Councillor Hutchinson as the Deputy Chair. As Councillor Smage has given apologies for today's meeting, Councillor Hutchinson, can I leave that to you to continue the meeting, please?
Are we voting?
Oh, apologies. Show of hands. Thank you. Sorry, over to you, Councillor Hutchinson.
Yes, thank you very much, Yolanda, and thank you, members. So moving on to item 2 on the agenda, do we have any apologies for absence?
We do, Councillor Hutchinson. We have got apologies from Councillor Smage and I understand Councillor Soloway and Councillor Lee as well.
Thank you. The minutes of the meeting on 30th of April have been circulated. Those members who were present at that meeting, do they form a correct record? And are there any matters arising from those that you would like to raise? From my point of view on agenda item 5, it was resolved that additional items of information be submitted to the committee on the cancer plan. And to my knowledge, we haven't actually received those additional items. So do you think they could be chased up?
I'll certainly do that, sir. Yeah, thank you.
Otherwise, I'm happy to propose those records, those minutes as correct. Can I see those in favour? Thank you. So can I remind members of the need to declare any interest that they may have in any items of the agenda, particularly disclosable pecuniary interest or any other interest which may prevent them from participating in any discussion of the items or participating in any vote upon the items. Councillor Lay.
Thank you, Chair. I'd like to declare another interest in that I am an employee of Harrogate District Foundation Trust, which obviously is a member of the West Yorkshire Acute Trusts. I am a nurse. I have no responsibility on procurement or any contractual work, and nationally my wages are set by a national agreement. Therefore, I have no personal financial benefit from any decisions likely to take place in this committee, but should there be, then I will declare those as a pecuniary interest at the time.
Thank you very much, Councillor Lay. Councillor Timbers?
Yeah, I'd like to declare that I'm employed by the Equality and Human Rights Commission. Obviously, we do work in this space. We act as a regulator for the Equality Act. I mean, there's nothing specific on the agenda today that might involve directly our work, but there's always a potential, and if it arises, then I will declare it. I'm also, I don't particularly work in anything related at the moment to health, although I have just published an advice note for the GP practices on the applicability of the public sector equality duty to them. and just delivered a webinar on digitalisation and equality, but I've moved on to other things, as inevitably you do with the Commission. But from time to time, I will be working on health-related work. If it's any way related to our agenda, then I will declare it. Obviously, as a non-material interest.
Thank you very much, Councillor Timbers. And I suppose I should also declare that I'm chair of an organisation called Doctors for the NHS, and I'm on the executive committee of Keep Our NHS Public, both of which campaign for the founding principles of the NHS as a public service. So I do have views on that, but no pecuniary interest. So do we have any deputations or petitions?
None received. None received.
Thank you. In which case, can we move on to our agenda item 6, which is the main one of the substantive agenda items on the operational planning for the on behalf of the Integrated Care Board, because we're all aware that there are major changes occurring in the way in which the NHS is organised in England, particularly as they affect the Integrated Care Board. So can I ask Ian Holmes to give a presentation on that?
Thank you, Councillor Hutchinson. And can I introduce my colleagues, Deborah Taylor-Tate, Adrian North and Dave Campbell-Hemming for this. And I think Deborah's going to take us through the slides. Thank you.
Do you need me to present the slides, to share the slides? I don't know if you actually share them. I'm quite happy to share them. Yeah, I'll pop them up there. Oh. This doesn't always work for me. Here we go. Good slideshow.
Yeah, that's coming up. Are you able to put them onto a slideshow?
There we go.
Lovely. Lovely.
Okay, so first of all, I'll just introduce. We've got a set of slides which me and Adrian are going to share, and Dave's going to chip in. I'll just do a first couple of slides, and then I'll pass over to Adrian, who's going to take us through the finance element, and then we'll look at the workforce and then the activity and the performance sections. So just thought it was really important just to set a bit of context about the operational plan. So I'm sure you are aware, but we'll go over it. It's an annual process for all NHS organisations, and that's the ICB, obviously our places across West Yorkshire, and then all of our providers. And it's looking at 3 areas. Excuse me. It's looking at our finances, our workforce to ensure our delivery, and then our activity. So how much activity are we expecting to take place across all of our services, and then the performance and the projected performance of all of those services. Obviously, it's quite complex. It's quite a complex process. It was complex before we became an ICB, but obviously we're now coordinating individual plans from all of those providers and across all of those places into one submission to NHS England. The process normally happens between around December through to March and April, but times can vary, and this year we're quite late in actually getting the guidance from NHS England. So that's how we work. Obviously, as I said, it is quite complex, so the collaboration, our partnerships and the leadership are really, really important within the process. And obviously the golden thread that runs through that is quality, and the quality of services that we are delivering. So that's predominantly how we approach it across West Yorkshire. I'm now just going to pass over to Adrian, who's going to take us through the finance elements of the plan.
Yeah, thanks, Deb. So, morning, colleagues. My name is Adrian North. I'm the Deputy Director of Finance for the West Yorkshire ICB. As Deb says, I'm going to talk through the numbers that I'll be talking about today are essentially the system position. So, as Deborah mentioned, it's the ICB position and all of the individual providers. So we've got 10 NHS providers. within West Yorkshire. This will be a presentation about all 10 of those. Sorry, could I just check, has somebody got their microphone off? On, rather, so I can. Thank you. So yeah, so just to on the first slide, just to note then that on the 27th of March, it's important to note that we did submit. Oh, sorry, there's still some feedback. I don't know if anybody.
I think it's Councillor Rose.
Thank you. That's gone to mute now. Thanks very much. Sorry about that. Yeah, so we submitted a break-even plan as a system on the 27th of April. So that's a key headline, if there was a key headline to take away from all of this. There was then an additional submission, as the slide notes, on the 30th of April. For West Yorkshire, there was very little change between the 27th and the 30th. It was really just a technical adjustments that needed to be made, where when we submit our plan to NHS England, if there's anything that they do some sort of consistency checks and make sure that individual systems have applied things in the same way. Wherever they haven't, they ask us to do a slight update, and that's what the 30th of April was, for us anyway. For a number of organisations, there were still systems that were off plan by the 27th of April, and there was an expectation that those would come back on plan by the 30th of April, and I think there were still 2 or 3 that weren't on plan by the 30th of April, but certainly for West Yorkshire, as an NHS system, we retained our balanced plan. And when I say balanced, it's the important thing to note about that is the underlying position isn't absolutely a balanced plan, or wasn't a balanced plan on the 27th of April. What we've done working with partners, and I'll come on to the principles in a second about how we got there, what we ended up with was we got to a plan which was still a 33.2 million deficit. And recognising that the national requirement was for everybody to live within their means and submit a balanced plan, the decision was taken by the West Yorkshire ICB board that we would put in essentially what might be called a planning gap. It was a system improvement target of 33.2 million held temporarily when we put the plans in against West Yorkshire ICB. So you would see that against the West Yorkshire ICB line. And it was agreed across the system that would be addressed through 25-26 and dispersed through 25-26 out of the ICB into the relevant places where any potential further savings might be achieved to address that £33 million planning gap. And I'll say a little bit more about that in a second, about the approach that we've taken to that. Also important to note that to get to the break-even plan, we had a requirement to deliver efficiencies of nearly 433 million, which is 6.7% of our overall system allocation. So a significant value again for the second year running in the 400 million plus. So very challenging from a financial perspective. And then we also received from NHS England notification of something called deficit support funding, or transitional support funding as it was referred to at the time of the plan submission, of 49.2 million. And that was in recognition of the fact that as many systems ended 24-25, there were a number that were either in deficit or had underlying deficits. And by underlying deficit, what I mean is if all the things equal, if you were to strip out the non-recurrent elements of the delivery of the plan in 24-25, there would be a deficit plan in 25-26. As I say, all the things equal, which often they aren't, but on that basis, and there was a recognition nationally that it would be very difficult for all systems to be able to recover in full in 25-26. So there was this distribution of the 49.2 to West Yorkshire. It was very variable across the country and relied on a number of different factors. In terms of that 49, just when we submitted the plan, our assumption was that was a guaranteed allocation that we would retain in the year. It has subsequently been clarified that it's actually now dependent on financial performance in the year. So that does add significant financial risk to our plans for West Yorkshire as an NHS system for 25-26, not least in light of the fact that we've got significant efficiencies delivered. And at the time of planning, we still didn't have a full way of identifying the 33.2 million. So there is significant risk in the plan. Could we go on to the next slide, please? Sorry, Deb, are you okay to move on to the next slide, please?
Sorry about that, it wouldn't move.
Oh, that's all right.
Again.
I'll just wait a sec. Thank you.
Oh, hang on. Not working.
Whilst you're doing that, Deb, I'll just carry on talking
Okay.
through, because I've got the planning slide in front of me. So what I was then going to just move on to is in terms. So I started that the presentation a second ago, saying that the NHSE national message was that all organisations and systems have to live within their means. That is kind of shorthand for making sure that everyone had to deliver a balanced plan and operate within the income and/or allocation that they receive as a system overall. There was also a key push to make sure that all systems could demonstrate improvements in productivity. You'll all be aware that there's kind of a national view, national NHSE messaging that across the country, the NHS has become less productive since COVID. And as a result, they pulled together a whole series of productivity packs, both for clinical services and non-clinical sort of corporate benchmarking services to be able to give us an idea about where systems might be able to look to identify productivity improvements. So as well as delivering, some of those would be cash releasing and some of those wouldn't be cash releasing. So what I mean by that is some might just help you deliver that kind of more for the same amount of money. Others might help you be able to deliver the same for less money, sort of thing. So two different types of productivity were identified as part of that piece of work, and we had to demonstrate that we'd made significant improvements in that as part of our submission. And we also had to demonstrate, and this I'm sure is something that Deb will talk about a little bit more in a second, is that we had to demonstrate overall improvements in system performance metrics, so the non-finance metrics. So there couldn't be a deterioration in any of those, as you would expect. So a very challenging ask. And that is probably why I would suggest that there was a headline submission on the 26th of February to NHS England, where almost no organisation submitted a balanced plan, because it was just at a point in time, and the headline plan, and this was the same for West Yorkshire, didn't include a balanced position. So we had to try and develop a methodology, or further develop a methodology, because obviously we had the methodology developed prior to this, but we had to kind of push it just that little bit harder to identify some of the 4 key elements that would help us address our financial challenge. The first was to consider system transformation, so essentially how the system could deliver services differently to support reductions in cost. That's usually working across the provider collaboratives or place collaboratives, however that would be best managed, but to try and identify things that could deliver some sort of transformational benefit. The review of productivity that I've already mentioned, so growth, uplifts, net of assumed productivity, and then the productivity packs that NHSE had outlined, both for trust and the ICB. Those weren't just trust packs, they were for the ICB too. Further enhancing the work that we'd started in 24-25 on grip and control. So as we started to report the 24-25 position, a number of financial risks started to manifest in that year, and there was a strong push from NHS England and others to make sure that all organisations could demonstrate that they had robust, consistent grip and control measures across all organisations. So things like our vacancy control panels in place, things like expenditure review panels, things like governance routes up to the board, all those sorts of things. It was really important that all organisations could demonstrate that as a minimum there was a set of about 20 or 30 recommendations that came through, and as a minimum we could demonstrate that we'd achieved all of those, some of which were more governance sort of things, some of which could potentially improve the financial position. So again, there was a significant focus of work on that. And also we undertook an external review in 24-25 by PricewaterhouseCoopers. They identified a number of recommendations as well, and again, part of the process for ensuring that we deliver a plan in 25-26 was to ensure that we delivered those recommendations. And then finally, if all of the above didn't get us where we needed to get to, there was something termed the difficult decisions framework, and this is the thing where you might need to look at truly difficult decisions, things where you really wouldn't want to do them. They might impact on services, they might impact on patient quality experience, all those sorts of things. To date, we haven't really had to rely on those. We've managed to get to the break-even position significantly of the first 3. Obviously, as we work our way through the 25-26 financial year, we have got those there to consider across all different places and all different organisations. But as at the time of submission, we went with a £33 million gap rather than push a lot of the difficult decisions that have these patient impact sort of things. And and equally, a lot of those things tend to be the ones where there's longer lead times because it might be stopping contracts on things, for example, and the contract is likely to continue for some significant period of time. So there was a framework. It's gone through various governance routes. At the moment, it's there for us to use in the event that we might need it in 25-26. So just a note then again about the where that got. So applying those 4 principles, we ended the year. We ended with a £33.2 million stretch target. Just a note since planning then. So what we've been doing since we've done this piece of work on planning, as I said, we didn't just submit the plan and then assume they wouldn't do anything further about it. We've done a lot of work across the system. There was work to devolve this down to place levels within the ICB and within the ICS to try and come up with options to address the 33.2 million. That is due to be transacted through a plan change in month 4 in agreement with NHS England. So whilst we had this 33.2 million, as I say, as a holding position in the ICB, it was never meant to stay there permanently. Once providers and the ICB identified its elements of it, the intention was to distribute that back out, and we've had confirmation from NHS England that we can do that next month, so we will be doing that. So I think those are probably the main points I'd want to pick up today. Clearly, I think that the main thing to note is that there's significant risk in the plans. The second year in a row that we've had efficiencies of £400 million plus. On top of the challenge, obviously we know we've got other external factors that weren't considered at the time of plan. Things like recent announcements of strike action, for example, in the past, that has put pressures on the NHS financial position. So we'll just have to make sure that through the various governance routes and the sort of meeting structures that we have, that we're keeping a very close eye on those things and ensuring that we deliver our plan for the financial year. So I think that's probably it from me from a finance perspective. I know there's probably questions. I don't know if we want to get through the whole slides or do finance questions first.
I think
easy either way.
I think if we could do the finance questions first, otherwise it will be rather too much of a slab of information to actually
no problem
from. So do members have any questions regarding this at the moment? Can I just ask in context, the 6.7% efficiency savings are across, not just administrative, they're across the whole of the costs of the spending of the ICB.
Yeah.
Can you remind me what have been the best ever levels of efficiency saving achieved by the NHS?
By the NHS or within? I don't know about the NHS in West Yorkshire. So in West Yorkshire, we had savings of around 400 and just shy of 400 million, about £396 million in 24-25. Those were achieved, but as I said at the start, with significant use of non-recurrent sort of income support, etc., that we received in that financial year. So that is why we're viewing this as a particularly challenging financial year this year, given that the efficiency is at such a significant level.
Because in my years working for the NHS, the best that was ever achieved by most organisations was between 1% and 2%. So a 6.7% efficiency target is really, and when we're talking about efficiency targets, it's about taking costs out of them or doing more for less. Although I don't think you're allowed to do more activity and count that as an efficiency these days. You used to be able to.
Yeah, that's right. So I think you're describing, so we used to have this thing called the elective recovery fund, and it was a variable for the last couple of years. And in that scenario, if you did more activity, you got paid for it on a case-by-case basis. That has ceased in 25-26, so that's no longer an opportunity for us. But you're right, Councillor Hutchinson, what has happened in the past is some organisations have had efficiencies around the 6-7% mark, but very few. It has tended to be around the, probably I would say in West Yorkshire, around the 3-4% sort of mark over the last few years.
Councillor Rhodes.
Thank you, Chair. Do forgive me for getting in late. I had a problem getting through the system, but I'm here. And I've picked up part of the financial headlines. Can we just recap, please, if I can, Adrian? local authorities over all the years have had to, at the end of the year, provide a balanced book budget. This has not applied in the NHS. So on that principle, can we just go back a little while? Ian Holmes mentioned to us about the 30% reduction last year, which you've indicated has come out at 400 million. Now, can we go back to when you did have maybe a lower deficit going forward? As Councillor Hutchinson has said, it seems to have grown like topsy over the years. So if we go to 23, 24, or even beyond that, assuming that you were there, Adrian, do forgive me, what kind of deficit have we been carrying forward? We'll say over the last 2 to 3 years.
So can I just clarify a point that you made at the start, if you don't mind? So I think you'd mentioned about the 30% reduction and that being 400 million. Those are actually two separate things. So the 400 million is driven by the fact that that's essentially the sum of all of the efficiencies that individual organisations across the system have identified. So this is probably something that maybe you missed right at the start. So what I was saying is this is a system report, not necessarily just the ICB report. So it brings in all 10 providers and the ICB. And that is the figure that's around the 6.7% figure that Councillor Hutchinson had made earlier. And that is about efficiency savings. That's not necessarily about the savings, but it's not at all, in fact, about the savings that ICBs have had to make over the last couple of years. So the 30% that you were referring to previously, that Ian has mentioned in previous meetings, was the requirement for ICBs to reduce their running cost allocation by 30% over the last 2 years. So that was a 2-year target, 20% 2 years ago, another 10% this year. So that was a specific ICB requirement to reduce its running costs. It's not the same as the 400 million. It's actually a kind of separate piece of work that we do across the ICB, and it doesn't form part of the savings targets overall. We just need to demonstrate that we're achieving efficiencies in running cost delivery within the ICB. So hopefully that helps just with that first point. In terms
it does indeed, because there are two separate issues here. And thank you, Adrian. Forgive me, as I said, I didn't manage to get in at the beginning of it. Can we then move on to the information of what deficits have been carrying forward then perhaps in the last 2 to 3 years?
Absolutely. So I mean, despite the fact that nationally we do 1 year plans, we do maintain a medium-term plan within the ICS and have done for a number of years. Across the system, we have actually delivered a balanced system plan in West Yorkshire for a number of years. So for at least 3 or 4 years that I can recall, we haven't had a deficit for a number of years. What we do though is each year it has become increasingly difficult to deliver that, because as the cost base goes up, efficiency requirements goes up. And what often has happened is that to deliver some of those efficiency requirements, there's been a greater reliance on the use of kind of non-recurrent measures that organisations might be able to deploy in 1 year that they can't in another. And that's what I've described as the underlying position. So that underlying position for the West Yorkshire system has been growing over the last couple of 2 or 3 years, because as I say, the non-recurrent measures to address it have been growing over the last 2 or 3 years. There is a piece of work nationally that NHS England have commissioned now to make sure there's a consistent review of the way of doing that, because the way that we do it in West Yorkshire isn't necessarily the way that everybody else would do it, and it'd be largely accounting principles, but there might be different views and nuances that different systems and different organisations may potentially take that we haven't taken. So that will be a piece of work that has been nationally driven to understand the start point and that underlying position for the medium-term plan that has now formally been announced by NHS England in terms of what we're going to be doing in the future. So I think probably to understand that, the underlying position in that context would be more useful, and perhaps something which we could bring to a future meeting once we've done that piece of work.
I think that would be very useful, Adrian, because we understand the position that you've gone through. Well, we're trying to understand the position you've gone through, because it was a very swift presentation with lots of issues that you've addressed. And you've just mentioned about a piece of work by NHS England. Obviously, the one system does not necessarily fit all.
No.
across the patch. So that'll be useful to know what's going to be a change in that. Will that change then from this piece of work have any further implications or will add value to the plans that have to be in place that we've already heard from Ian about moving forward in year 25 and 26 towards the 10-year plan?
So I think what this will, the main reason for undertaking this piece of work that I've just described is for us all to understand the start point of. So what's happened over the last few years is NHS England have often provided systems with some sort of non-recurrent support in the year. It's been badged differently in year as something or other. That, for example, I've mentioned this year the deficit support funding. So we in West Yorkshire received £49 million deficit support funding in this financial year. The view nationally is that that will disappear next year. There will be no deficit support funding. So like I say, all the things equal, if we delivered everything that we said we'd deliver in our plan, we would be £49.2 million in deficit if we didn't get our deficit support funding. And that was provided on the basis that systems have had underlying positions that have been deteriorating over the last few years. So what this piece of work is doing is trying to strip out all of those things in a consistent way across all different systems to make sure that people are applying the same assumptions. So we've mentioned, for example, there about the elective recovery fund. In the past, some systems have deemed that as recurrent, some systems have deemed it as non-recurrent. You know, so this is about making sure that NHSE can properly measure each organisation's underlying position, and then from that will then there'll be a clearer set of announcements, I would hope, from a national level from NHS England about which elements of those will then become recurrent funding going into baselines going forward. So I think it has been indicated, for example, that the deficit support funding will become recurrent, but not necessarily in the distribution as it is now. It'll just be a recurrent allocation to the NHS that can be part of the way we develop our plans over the next 3 to 5 years. And that's where we'd need to make sure then that from that start point, we're building it up to make sure that we're applying the various elements of the 10-year plan. But we can do that over a medium-term plan better than we can in a one-year cycle. The problem that we've always had in a one-year cycle is it's really difficult to start to enact some of the things that are in a longer-term strategic plan when you only get allocations for 1 year, and you don't necessarily know what the allocation is for next year either. So you don't know if they're going to be incentivising certain things or disincentivising certain things until the next year's come, until the next year's planning guidance comes, and that tends to be when you find these things out. The idea now about having the longer term plan running alongside a medium term financial plan is that those sorts of things can be properly identified and properly addressed. So yes, I would very much anticipate that this work would allow us to develop a consistently understood underlying position for each system in the NHS, and then build a medium term plan that links into the 10-year plan, because we'll have longer term allocations to allow us to be able to consider that.
And just to follow through on that and play devil's advocate, if I may, Chair, one could say that there's been a dependency on the deficit support fund continuing, which basically was the trusts or anybody else, if it was applicable, and the ICB, you would be carrying forward a deficit budget because you had a dependency on this 49 million. So the 49 million basically then has balanced your books in the provision that you'd planned for 24, 25, 26. The question that follows that then through you, Chair, is a supposition, Adrian, that this fund is going to continue. It's continued to fill the hole at the moment of 49 million. So what is the future going to be if that supposition of a continuation of this deficit fund doesn't happen? So
deficit funding is another example of something that has been another non-recurrent fund that we've had in this financial year. So 25-26. So you're absolutely right. It's not a devil's advocate thing at all. It's absolutely right. Other provider organisations have said, and their boards have said, we can deliver our plan this year, but going forwards, if that funding is removed, it'd make it significantly more challenging from 26-27 onwards. And but that's why I think even nationally, NHS England, they have recognised that the funding mechanism for the NHS has become very complex over the last few years. It used to be far more straightforward than it is at the minute. It's become particularly complex with a number of non-recurrent allocations, with changes to the way ERF works, with there's also a significant piece of work going on about acute services reviews and whether we move to a different payment mechanism for that, for example. So it would just be one of those things in the round about understanding our opening position going into 26-27 and whether there is or isn't a national fund to replace it. I mean, I don't know that at the moment, but if there is, they wouldn't call it deficit support funding. I suspect what they would just say is, actually what we're doing is we're saying the recurrent allocation for the NHS is now X, which would be last year's number plus potentially deficit support funding added back in, plus the growth that's been announced nationally about the sort of growth in NHS funding over the next couple of years. It would all just form part of that overall envelope. And then what would happen is that there'd be discussions then with NHS England about how that would be distributed across the system. So it may or may not come back to us in quite the same way to West Yorkshire. And until we know how that would flow, it's really difficult to understand whether or not that'll be a benefit or a disbenefit to us. There is potentially a scenario which could be that we get more deficits, or more, not deficit support funding in 25-26, but a greater share of it in West Yorkshire, because we are kind of 5% of the national average, and our 49.2 probably isn't 5%. It's probably slightly lower than that, because other systems across the country have had significantly worse deficits than, or underlying deficits than we've had in West Yorkshire. So I think almost all systems have received deficit support funding over this financial year. Certainly in West Yorkshire we have. So certainly in North East and Yorkshire we have. So all four areas within our region have received deficit support funding, and more nationally as well. But the distribution of it hasn't felt very equal. So if I'm honest, I'm not quite sure how that has been calculated by NHS England. It was a figure that was given to us as a figure that was given to us. So. But if you were to sum it all up, I gather the figure's about £2 billion nationally. If you were to sum that all up, it could be beneficial to West Yorkshire going forwards, depending on how they add it into our allocations or not.
Thank you. Can I just follow through on that one, Chair, because this is very interesting for anybody who's not been involved in the health system regime of financial management to understand that the government has actually had a deficit support fund to enable trusts, and now the ICB, since it became full power, as I will say, full legislative power, to move forward. And I've been listening to this before, and this is why I'm asking the questions of Adrian in the financial planning. I do totally agree that 1 year financial management is not in any way, shape or form suitable for organisations to plan for visions for the future, and particularly in terms of aligning their budgets. We're in a world where everybody's had to cut their cloth according to their means, as we all know. And the last question, perhaps to yourself as the financial manager for the West Yorkshire ICB, and Ian in attendance, is at this point, one could say, in layman's terms, that the governments have been bailing out deficit budgets, in our case, 49.2 million. And we're not alone. It's a system that's been in place. Now things are changing in terms of budget management and financial management. And I think the system that we have at the moment, when I come round to it between yourself and Ian, is if at this particular stage, the assumption that the level of support that may be coming in the future is less than what has bailed out this year, 49.2 million for us. What plans will there be outside of what you're having to look into at the moment to bring in a situation where the dependency level can be reduced in case of a deficit moving forward?
You mean across the West Yorkshire NHS system? Do you mean in terms of delivering a West Yorkshire balanced plan for the future?
I mean from the ICB board here this morning that we're dealing with.
So I would suggest that would equally build into the medium-term plan work that we're just starting to kick off now. So as I mentioned before, we have had an underlying deficit plan, as I'm sure all systems will have had for a number of years.
Yes,
What we're
Ian,
saying
can
is
I just
that
interject, because I know there's two more coming in. I'm aware of that. The question is, if the assumption is that we don't get the same amount of money, and I hope we're all wrong in that, to bail out any deficit and to give
Right,
support
okay.
to the
I'm with
organisation,
you. Yeah. So I think
is there within the system at the moment, and Ian is indicating he wants to come in, is there within the system at the moment a consideration that if that assumption is less than supportive, what plans would there be in the financial regime to deal with it?
so Ian, do you want to just come in and then I can chip in at the end?
Let me have a try, Adrian. Thanks, Councillor Rose, for the question. So I think what we're describing is a move towards greater transparency and simplicity of the financial system. So what's happened in the past, as Adrian has said, is that the NHS gets money, it plays most of that out to ICBs, and a bit is held back and used to plug gaps. And we think that number might be about £1 billion. As Adrian says, West Yorkshire tends to be a relatively low deficit system compared to some others. So all things being equal, if that money was played out through core allocations, we might benefit from that being played out through core allocations rather than giving it to us as a sort of a financial adjustment at the end of the process. So that's the first thing. I think generally we'd support a move towards a more transparent and simple financial regime where the money was played out and you have to live within your means, because otherwise you're kind of rewarding poorer financial management. So I think that's the first point that I'd make. The second point that I'd make is that our plan isn't going to change for this year. The money that we've got is the money that we've got, and we need to deliver the very stretching financial targets that Adrian described. What will happen for next year is that we'll be given an allocation and uplift for next year, and we'll be expected to develop a plan to live within that. There is a chance, Councillor Rhodes, that we lose that 49 million support, in which case the financial ask will become 49 million more challenging next year. So this year that number would have gone from 400 to 450. There's also a chance that because the money gets played out through core allocations, it benefits our system because of the way that the allocations work and the fact that we're not a high deficit system. So we'll need to deal with that in next year's planning process. But I guess what I think I'm hearing from the committee, in my view, is that a move towards simplicity and transparency and getting your money and being asked to live within it is probably a step in the right direction, because the existing system is incredibly complicated. Adrian, I don't know whether you want to add anything to that.
Thank you, Ian. I'm happy I'm happy, Chair, because Ian has just reiterated what Adrian has said. And I think a lot of us knowing the systems that work within the health service, as opposed to what we deal with and having to have a balanced budget, and we can't go ahead on a deficit, that the system actually is in some way, through the previous process and maybe for the future, reliant on this government support fund, which people might think you're bailing out mismanagement of systems or having increased services that you haven't had the finances for. So I appreciate that from both of you, but I think it's something that's going to have to come back when we do know what the allocation is, because there may have to be some changes again in terms of services. So I'll leave it at that, Chair. Thank you, Chair.
Councillor Lay, you've been very patient. Can I bring you in?
Thank you, Councillor Hutchison. Thank you, everyone. I just wanted to sort of put it in perspective, really. One, when you take the savings or the efficiencies plans of 432 and extrapolate that as 6.7% of your overall allocation, ChatGPT tells me that's a budget of nearly 6.5 billion.
Right. Yeah.
Want to place a 49 million deficit in context. That's 0.76% of that 6.46 billion. If my maths is right, or if my assistant at ChatGPT's maths is right, yeah. So we talk about large numbers, and everybody talk about, and millions sounds lots to everybody. but actually the NHS deals in billions and hundreds of billions. And I'm not diminishing the 6.7% allocations efficiency savings. It's a huge challenge for the NHS. We also know that the NHS has gone the same way as local authorities in that our budgets, and I've only been a councillor 13 years, but our budgets have been squeezed, of course, and depending on people's views, significantly. But what actually happens is you have to go cap in hand to central government, because they might say, here's some money for this project and here's some money for this project, and etc. So you end up and you start having to you're basically bidding with other local authorities for a restricted pot of money, and then halfway through the year the council will come and say we've got £3 million by central government to do X, Y or Z. The NHS has gone very much down the we're controlling the finances much more than we ever used to, and I suspect through the year pots of money will become available that the ICB or its successor organisations will apply for. It doesn't help, though, that approach doesn't help. That centralisation of money doesn't help, because it doesn't help for planning, and it's non-recurrent, as you say, Adrian. Very often we've always been bailed out in the NHS as well, just whilst we're talking about non-recurrent, always been bailed out, and they might be calling it a deficit, whatever it is now. Anyhow, back to my point. Of that 432 million that we need to save, do we have a breakdown of where those savings are going to come from? Is it going to be secondary care? Is it going to be primary care? Is it going to be public health? Is it going to be split evenly across providers? Because obviously there's more than 5 providers. The 5 providers that make up the acute trust are just the secondary care providers. There's primary care providers and mental health providers. So do we have a breakdown of where those savings are going to be expected to be made?
Yeah, so the all of the budgets that I've described, all of the savings that I've described, all of the plans that I've described, they are all bottom-up plans essentially. So they're the sum of the ICB's plans and the 10 provider organisations. So we've got 10 in total. So we've got 5 acute trusts, we've got an ambulance trust, and then we've got 4 mental health community trusts. Each of those has developed its own plan. So we don't as an ICB set a target for each of those organisations as such. They know that the target, as it were, is that they've got to break even. So that living within the means, that is, whilst it being a system target, it is measured at a system level. Our expectation in West Yorkshire was that each individual organisation would set a break-even plan. So that's the kind of intention that we set out with. And on that basis, each organisation has come up with its own list of plans. So we have a full analysis of all of those. They provide us with a whole load of detail on those, provide NHS England with it as well. What it doesn't include is if you take any savings that GPs might need to make in primary care, for example, it wouldn't, those aren't in there. These are the 10 NHS provider organisations. It doesn't include non-NHS provider organisations, independent sector, for example, things like that. It just purely includes the NHS organisations within West Yorkshire. But yes, fully detailed, fully transparent.
Oh, so those figures have come from the organisations, the 10 organisations. You've aggregated them all together and come out with this total. It hasn't come from you to the other. That's fine. Exactly. Thank you for that clarification. So it's adding up all of those providers.
That's right. Yeah.
Thank you. Thank you, Chair.
But having said that, you referred to the action plans that have been drawn up by PricewaterhouseCoopers that presumably do feed into it, that aren't coming from the bottom up. Are those action plans actually published anywhere?
I don't know if they are actually, but they are bottom up though. They are the PricewaterhouseCoopers wasn't whilst it was commissioned by the system, it was a report that fed back into each of the 10 provider organisations. So there were bespoke recommendations to each of the 10 provider organisations and the ICB. And the intention was to help guide opportunities that they might be able to identify in 24-25 that then probably would have had a tail into 25-26 rather. So that absolutely is an organisational piece of work, not, although it was commissioned by the system, it was an organisational piece of work. So it is still bottom up by organisation. So that might have informed, for example, it might have suggested areas that, when I said to Councillor Lay, for example, that it was made up from, if you just take any one of our 10 provider organisations, they will have had a PwC element of their report. It may have said you need to look at something in that report. They could have included that in their efficiency plans or not, depending on whether or not it was a cash releasing efficiency or not.
Previously, when savings have had to be made, well, there's been a lot of talk about poor productivity or lack of improving productivity within the NHS. But when savings have had to be made, that often snuffs out attempts to improve productivity by changing how you're doing things. So I was wondering what protection there would be from spend to save projects. So we were hearing last week from the Yorkshire Cancer research project about the active together prehabilitation and rehabilitation for people undergoing curative cancer treatment, where their health is maximised largely by the input from physiotherapists and other bodies, and that saves something like £360 per patient in shorter lengths of stay for treatment, better health during their cancer treatments, and quicker recovery. And similarly, there's work on improving staff conditions and health improvements that's been carried out in Buckinghamshire NHS Trust that's referred to on page 105 of the 10-year plan as to how that's reducing sickness and improving staff retention at Buckinghamshire Trust. That does, again, requires things to be done differently. And the integrated neighbourhood teams, as described in the 10-year plan, it shows how that can reduce the actual costs per patient. So I was just wondering whether those sorts of projects would still be going ahead within West Yorkshire with a view to improving productivity, even though there is an upfront cost to them.
So as a general principle, those would all be things that we would consider, absolutely. So when we look at the when I describe those productivity packs, for example, those kind of things won't be in it. What's happened is that other opportunities have arisen throughout the year, and if there's a potential invest to save sort of opportunity, that is something that both the system and individual organisations within it would still consider. So there's nothing to prevent any organisation from coming up with a business case that says they need to invest £1 million to save £2 million or something like that. That those sorts of schemes have been going on for a number of years. There's nothing to prevent that from happening going forwards, regardless of the financial regime. So Ian, did you want to just?
Yeah, I mean, just to say the stuff that you described, and Councillor Hutchinson is a really important part of the plans. You know, the financial context really difficult, but we have been able to identify just over £4 million this year to support the development of integrated neighbourhood teams, recognising, you know, that you know, some of the digital infrastructure you need to get them working effectively, as well as the support of the teams to work in different ways across different organisational settings is really important. So yeah, it's the transformation aspects of this and how we deliver services in a different way that better meets people's needs, but also supports them in the right settings is a key part of the plan.
Can I, before we move on to the staff measure, can I just ask one further question? Obviously, strict financial controls are vital if we're going to achieve the break-even budget position. But in The Guardian and in the Sunday Times within the last few months, they've reported that the spending on cataract surgery, elective cataract surgery, has gone through the roof, particularly in Gloucestershire and West Yorkshire. This is through optometrists being able to refer patients directly to private independent cataract surgery organisations without any limit on the number of people that they send, without any limit on the severity of cataract, and the impact on people's daily lives, and that those companies that have set up these cataract surgical procedures can simply come along to the Integrated Care Board and say, we're doing this, we need a contract from you, and the Integrated Care Board has to give them a contract and has no say in the volume of surgery that they carry out. And the estimate that's been reached by the Centre for Health and Public Interest from Freedom of Information requests is that the excess profits from this is about 32%, and that money comes very close to the deficit of all the integrated care boards last year. So we're not talking small beer. So in terms of financial controls over this kind of operation, is the Integrated Care Board able to exert that control?
I mean, you've articulated the issue very well there, Councillor Hutchinson. So essentially, there's something about the way that the NHS works with private providers, but where if there's a provider who's able to deliver a service, they can come in and as you say, because they can offer very, very short waiting times, they can deliver a lot of activity. One of the things that we have or are in the process of implementing this year, which doesn't solve the problem, but which will help, is a minimum wait time for people receiving those cataract services. So we're looking to introduce a minimum wait of, I think, 16 weeks. It's around that sort of period of time, which still means that in the vast majority of cases, the treatment is faster than if it was through one of our statutory NHS providers. But what that means is that kind of slowing down of the flow of patients into those services will save us about £4 million this year, I believe. So it is a kind of a feature of the policy framework that we're working in, that private providers can get contracts for these kind of services and deliver huge volumes with very short waiting times. And in the financial position that we're in, is that the best use of resources that we've got? Probably not, and that's why we've looked to introduce this minimum waiting times, just to try and improve the equity really, and save some money on this so that it can be spent elsewhere.
Absolutely, because as you're aware, there are long waiting times for people with potentially blinding conditions like glaucoma and diabetic retinopathy, when money is being diverted towards fairly trivial degrees of cataracts, which are not actually impairing people's daily lives to any significant extent. So it's being able to actually direct the funding to where it's most required. Okay. Thank you very much for that. So can we move on to the workforce side of the presentation, Deborah?
Yeah, we can. Thank you. Thank you, Chair. Dave, can you show? Okay, the next slide, please. Oh, it's not working again. There we go. It's quite a short presentation on a workforce because we're still waiting to get the numbers. There's quite a lag in our performance around our workforce. So I'm suggesting, Chair, that we bring those back to another meeting so that we can actually have a more in-depth discussion about where we are with our workforce. But I'll just go over a few headlines from the plan. I think it's really important to understand, obviously, our biggest cost. We've just spent quite a while talking about our finances. Our biggest cost is obviously our workforce. And last year, we managed to grow our substantive workforce across all of our providers and all of our services across West Yorkshire. And that allows us to reduce our reliance on bank and agency staff, which I'm sure all of you are aware is quite a cost pressure for us. We saw a strong workforce growth in our hospital and community services, around 3%, and also in our general practice of 2%. And obviously that was largely driven by the increase in our resident doctors, formerly known as our junior doctors, and in trading posts as well. And that's across both acute, community and general practice. The focus this year will continue for us to manage that vacancy management and further reduce bank and agency staff usage. And again, I'm sure you'll all be aware, is also, obviously, there are savings to be made in the ICB, also in all of our NHS providers around efficiencies around their non-clinical workforce. That's really the headlines around the workforce. And as I suggest, I think we come back with a much more detailed presentation on the numbers and exactly what we're achieving this year. So if there's not any questions, I'll move on to the activity. If that's okay, Chair.
Well, Councillor Lay?
Thank you. Yes, I just want to share my professional experience of how that plays out at the clinical end. So as members know, I'm at Harrogate District Hospital. I'm emergency care senior nurse. So I work across SDEC and A&E. For a very, very long time, our A&E relied on quite significant numbers of bank nurses. Many of them were from the private providers because our in-house NHS1, NHS professionals couldn't supply the need. Our trust, through I assume money from the ICB or wherever money for the NHS comes from, it's so bloody complicated, I don't know where that comes from, but they increased our staffing establishment. Now we spend hardly any money on bank and agency staff in our A&E and in our SDEC. So it does eventually get down to the clinical level. This isn't, you know, you do see the difference. And of course, the benefit of that is that we don't spend so much money on expensive agency nurses, but you also get continuity of care from having a stable workforce. You can train and educate the nurses because they're permanent, they're substantive. You can improve outcomes, etc. So it is a win-win. I just want to share my personal experience, professional experience. Thanks, Chair.
Thank you. Yes, and I fully recognise what you've described. You know, because having people who work regularly in a particular setting with within a particular team is so much more valuable. The value of teamwork, of working in close teams, is often hugely under recognized by people who just see everyone as being the same. Can I just ask, though, in terms of the figures that you've got, the increase in the number of resident doctors, I thought there was very little increase in the number of actual formally recognised training places, and that the big increase was in doctors working in locally employed contracts. Am I wrong there? It would be nice to see a split between people who are in bona fide training schemes and those who are what we used to call the lost tribe of SHOs back in the day, that were there doing a job of work but weren't actually formally engaged in the career progression training program.
I think Ian's going to come in on that one.
I suspect you're right, Councillor Hutchinson, but maybe that's one that we can provide figures for you outside this meeting.
That would be good. And also, when you're providing the figures, you've shown how there's been a substantial increase in the number of positions for so many grades of staff. But how many of those are actually filled? So it's what matters is the bodies on the people who are actually there at the work phase, not the number of theoretical posts that there are. So if that could be added in, the vacancy rates, which for some disciplines have been very, very high, are those continuing? And similarly, if you could split the GP numbers between fully qualified GPs and people who are on the GP training schemes, because we know many of those, when they come to the end of their training scheme, they can't get renewal of their visas if they're from outside of this country, and they return to their original. They have to leave this country. So thank you very much. If you'd like to go on, if there are no other questions from members, I can't see any hands. If we could move on to the activity side of things.
You, next slide, please, Dave. So the next couple of slides that you've received will have given you some headline details around where we are with our plan, and they were all based on where we were as a baseline in December, what we put in our plan, the national target, and then whether we were whether our ambition was to exceed the target or whether our plan was measured and we said we're going to achieve, but we're not going to quite hit the plan. I'm not going to go through every single one of them, but I'm just going to pick out a couple just to give you exactly where we are now, so where we are tracking against our current plan. So the first one I thought would be interesting is around our referral to treatment in 52 weeks. So this is around us completing treatment for people within 52 weeks. And I'm sure, obviously, since COVID, our waiting lists have grown. And whereas before the target for the referral to treatment was 18 weeks, obviously during COVID and after COVID, it's gone up to 52 weeks. But we are looking to obviously bring that back down through this plan to 18 weeks over the next 12 months. But for the 52 weeks, our target, the national target, is 1%. And at the moment, at month 3, we are tracking around 1.4%. That target is for the end of March. So obviously we've still got some work to do, but we are on track to achieve the national target. We had a very, very ambitious target within our plan to reduce this to 0.55, and obviously we are tracking against that as well. But at this moment in time, we are tracking at that 1.4%. Looking at our overall waiting lists, again, all of these targets are for the end of March, so I think that's quite important to note. We are looking to have a waiting list of 225,802 people, and at the moment we are off that target by 893 people, so we are making really good progress on that elective waiting lists, and that's obviously a real focus, is to reduce that. Comes with that is how quickly we can see people for their first outpatient appointment. And again, we're looking at trying to do that within those 18 weeks. And our ambition is to do that just below 75% of all people will be seen within those 18 weeks. And at the moment, waiting for the updated figure, but we're approximately around 52% of all people across West Yorkshire are being seen within those 18 weeks for their first appointment. I know last month and you had some detailed presentations from the Cancer Alliance. Just a quick update on that. For the 62-day cancer standard, we are on track of our trajectory, but for the 28-day faster diagnosis, we're actually tracking just below target currently. But these are both areas where we do perform extremely well. So obviously we've got the next 9 months to start to work through some of that. For our diagnosis, and that's an aggregate position across the 6 main diagnostic tests, the target is 95% nationally, and we do very well, and our plan is an ambitious target to get us to 95.78%. Can you go on to the next slide, please, Dave? The next slide, we're going to look at mental health and learning disabilities, a challenging area that we've always had a challenging area around our out-of-area placements. So it's placing people out of West Yorkshire.
Excuse me, Chair, excuse me interrupting. Before you go on to the mental health part of this presentation, very interesting in terms of the percentages here that we have on the commissioning metrics. You've just mentioned the 6 main diagnostic tests. Some of this information obviously is very technical in terms of your presentation where it's needed. Do we and could we have a breakdown of what are the 6 main diagnostic tests? Because I think that would be useful to know when we in our constituents get concerns about people waiting weeks upon weeks upon weeks, even to see somebody in ophthalmology, 6 months, 9 months, etc. So the basics of the people on the waiting lists is very important. The time scale is very important. As our chair mentioned, 18 weeks for the cataract treatment that people need, which isn't as vital as some others, but it is vital to that person at the time. They can be with a private provider within 8 weeks. So there's reasons and to's and fro's amongst it all. But can we have a breakdown of what these 6 main diagnostic tests are? And the number of where we're below here by the 0.25% return to treatment over 52 weeks. Is there any of that percentage, that return for treatment, associated with, let me put my words very carefully on this, with in terms of the patient being discharged too soon and has to return?
That's referral to treatment times, RTT.
Yes, that's what I'm speaking about, Chair. Referral to treatment times. Where is there, or is it incorporated in that, where patients have got to refer themselves back to hospitals, and I'm told that that is classed as a second patient? Has that system changed? And if it has, it's got to be commended, because it was doubling up on the same patient. So when we're speaking about percentage return treatment complete over 52 weeks, is there any element of patients having to return in that heading because they're the same patient but they're counted twice?
I would have to go away, Councillor Rhodes, and have a
Okay,
look at
that's
that.
fine.
I'll have to go away and have a look at that.
Yeah, that's fine. Okay, we look forward to that. Thank you, Chair.
Yeah.
Yes.
And can we have a breakdown of the 6 main diagnostics, please?
We can give you that, and we can give you the percentage that we're achieving across all of those diagnostic tests, because obviously it's an aggregated position, so it's a really good aggregated position, but there are a couple of areas where we are challenged, and you can see that through the breakdown, so we'll be able to get that to you as quickly as possible.
And at the same time, being as you've mentioned it, can we then have a breakdown of the areas that you've just mentioned that are challenging?
Yes, we'll be able to give you that.
That'd be good. Thank you very much.
Thank you. Councillor Lay.
Thank you, Chair. Just very rapidly, my assistant again has told me the 6 diagnostic key NHS performances are the MRI scan, the CT scan, non-obstetric ultrasound, so non-pregnant women, non-pregnant, women, I don't know, non-pregnancy cases, echocardiogram, so tracing ultrasound of your heart, endoscopy and electrophysiology tests. They are the 6 that we monitor. And it also did tell me that these 6 diagnostics recently checked, West Yorkshire is performing well above the national average based on publicly available information. So good old AI.
Chairperson, can I thank Sandy for that? That's very useful. And we're not here just to flip over to Google or somebody else. What we're here to do is look at the reports that are presented to us, because this system that we have here and is open to the public information is relative to the questions that we ask here, because not everybody is on Google out there. And our reports here today and forever at all our scrutiny meetings must contain the appropriate information that any member of the public who would be looking at this today will understand and will know the areas just by it being in a report. We do get lots of reports where we have details like this that are coming off the system that you're working to, and that's great, and thank you very much for that. But they've got to be followed with an understanding that you've just brought up and mentioned a challenge. Well, where are the challenges? Why aren't we knowing what they are? Because then it gives us some details in terms of our own authority, our own trusts, and indeed the position that all trusts are in, particularly in terms of orthopaedics, when we're speaking about getting waiting lists down of referrals to the private sector, which most people are totally enamoured with and agreeable to take them out of pain. So let's get down to the basics here in terms of people looking in at this morning, the community out there interested in health, but may not be a Googler or a little person with a machine beside him. Forgive me,
absolutely.
Sandy.
So therefore, for information, and I quite clearly said for information,
Well,
these are the 6 tests.
You're new to the committee, Sandy. You're new to the committee, Sandy, and I do agree with that. But from a position of this committee, it is down to the reports that comes to this committee that involves all authorities under the auspices and direction of our chair and deputy to have that information in them and not scanned over.
No,
I agree.
And we've been reassured that that additional information, that breakdown of those main categories of the diagnostic tests and the relative numbers in each of them will be forwarded to this committee, because obviously there has been a significant hope pinned on community diagnostic centres and the investment that's gone into those, that those will produce that capacity for MRIs and CT scans and some of the other tests. And if they aren't actually delivering that, then we need to understand why not, and whether it is the fact that you can't have radiographers both in the hospital and at a community diagnostic centre. So the shortfall is not the shiny bits of kit, but the people to operate them. These are things that we do need to be able to keep an eye on. And so the figures that you're requesting, Councillor Rhodes, are perfectly pertinent to this question. But thank you, Councillor Lowe, for indicating roughly what those categories are likely to be. Okay, would you like to continue, Deborah?
Yes. Okay, thank you, Chair. I'm just going to pick up on a couple of the mental health. Like we said, picking up on a challenge. We know that we do have some challenges around out of area placements. The national target is 0. That would be very, very ambitious for us. Our plan is to get down to 14 by the end of next March. And at the moment, we are tracking at around 30 people out of area, out of West Yorkshire, receiving inpatient mental health care. That is improving. So as you can see right at the top, we had 51 in March, and we've now got that down to 30. So there is an intensive amount of work going across our mental health providers, our mental health collaborative, to manage that number. Obviously, that is not good care. Well, it's good care, but obviously they're farther away from their families, and that is a very expensive care. So that will be also included within Adrian's productivity and efficiency plans around keeping as many people as possible inpatient mental health within our West Yorkshire providers. The other area just to pick up on there is the talking therapies. This is an area where we do perform extremely well. Our plan is looking to be above the national target, and at the moment we are on track to achieve that. The other area to consider is the learning disabilities and autism, and we achieve extremely well on our annual health checks delivered by our general practices, and we've performed above our target of 75% of this over many years, and we are on track to maintain that this year as well. And another area is our inpatient care for learning disabilities and people with autism, and that's about trying to keep people obviously in the community, in their own places of residence. Our target is to only have 53 people in inpatient care. There's still work to do because we're currently tracking that at around 71 people. Does anybody want to ask any questions around the mental health before I go on to the ambulance service?
I can't see any questions there. Can I just ask, average length of stay, is that in days or weeks?
That's in days. Oh, Dave's coming in. Dave, over to Dave.
Yeah, sorry, Deborah. Yeah, I was going to just confirm. Yeah, it's days. Yeah.
Okay, thanks. And I mean, what measures are taking place to try and there tends to be very little control over how long somebody is in one of these beds, which I believe are mainly provided by the private sector. So in terms of verifying the need for that care to continue for so long, what influence does the ICB have?
They wouldn't all be private providers, so that would be within our mental health trusts as well. I'll bring Dave in because Dave works with our mental health collaborative, and he'll be able to give you a bit more of an update on the work that's going on around that.
Yeah, so for the in regard to the length of stay position, that would be in our mental health NHS provider trusts would be primarily where those beds would be. For the out of area beds, because we've discussed both those metrics, that's more variable, and yeah, there can be private providers there. So for the work's going on across those that links into both those metrics, and we've mentioned both of those. There is a piece of work going on across our mental health programme focusing on what's called there's 10 high impact discharge interventions, which is a national piece of work that's sort of published in the national planning priorities, where they're looking at how the different services work together, including health and social care, and they're working through that. And that's a piece of work that's going on from our mental health programme, looking at each of those actions. There's been work baselining some of those, and and how we can progress those in year. So that supports some of the length of stay, particularly where we look at what we can shared learning opportunities, and we get support from NHS England on that as well, where our North East and Yorkshire regional NHS England team look at how we're doing and how the other integrated care boards across North East and Yorkshire are doing, and if they see opportunities for shared learning, they'll put together things like community of practice events where we can share good practice. So that links into that work. The bit, as you mentioned, at private providers is an area that is it's a valid point that is a more difficult area to impact on providers that might be in different parts of the country, and there is work there where we're trying to we try and link in with providers we use regularly, and particularly if we've got someone can be classed as out of area if they're close in our geography but not within our NHS trust. And that's where we've got private providers such as Signet locally who provide a reasonable amount of inpatient mental health beds outside the NHS, and we've done really close work with them to build relationships and networks and really improve that how we continue care and have that relationship, because that is difficult to do when it's providers further away, because as you say, we're linked in with them. But yeah, lots of work's on, and each provider has kind of bed flow teams who work really closely and track anyone that's out of area and keep in touch with those providers as well. So there's a lot of work going on in that area to try and improve that position.
Thank you very much. I don't see any other hands, so would you like to move on to the ambulance service?
Chair, I was indicating, I beg your pardon.
Oh, sorry, I beg your pardon.
So that's okay. That's okay. Right. Thank you for the report. And always very interested in what's happening in terms of the mental illness field. At the bottom of this report that we've got today, I've identified some areas here that have just gone totally blank in terms of targets and variance on target because there isn't a target set. One of them is the reliance on mental health inpatient care for adults with a learning disability. And that was in December 24. You had a baseline of 36, and then 25-26 is a reduction, and after that there's nothing. So can we assume those 28 just disappeared? And then it goes on to say reliance on mental health inpatient care for autistic adults. And we have the same principle there. And then we have a reliance on inpatient care for people with a learning disability and or autism care for children. Well, I think there's an explanation needed around those 3 points at the end of this report. Bearing in mind the national picture in terms of the number of children, young people, are actually being diagnosed, rightly or wrongly, and I'm not disputing the fact either way, the number of children that are being diagnosed with autism or part of the autism spectrum. So why haven't we got more information on that? You will note as well that there's probably an alliance with the number of children who are SEND, who are needing special support as well. And that's a national issue. So what's happened to all of that? The inpatient care for people with a learning disability and or autism. So why from December 24, you've got a baseline of 7, 25-26 is 7, you have a target of 8. Now, where do you, I'm sorry if I'm being too pedantic, but these reports are not enough for people to understand and for us to give information out in terms of the overall picture when we have our own scrutiny meetings. What and why is that seem to be in those 3 topics at the bottom of this report, which nationally and locally are getting a lot of publicity because of the strains and stresses and the diagnosis of some children and adults. And the difference between a diagnosis of autism and the difference of a diagnosis between dementia, they are similar in need of support and attention. So can you just tell me why those 3 are so blank in information and so lacking in information in terms of our understanding what's happening in our communities? And I'm sure through the referrals from such as the autistic spectrum and through SEND in support for children, that it is not an accurate picture. And forgive me if I'm getting the statistics wrong, but I cannot see that those numbers in any way reference what's happening out there in our community.
The reason they're blank is that there isn't a national target. So it's not that they've been forgotten. It's just that, correct me if I'm wrong, Dave, but that's my understanding. There isn't a national target for us to hit, is it? So that the first 2 ones is where we were in December, what we're putting in our plan, what we're hoping to achieve in our plan. There is no national target within them. I think that's the explanation, but correct me, Dave, if I'm wrong.
It looks a bit, I suppose it's not very clear on the slides. Yeah, we're not getting judged by those. We've got 2 lines there. We've got the first line that says about the Councillor Rhodes rightly pointed out there. Yeah, that we've got 2 lines. One is about the mental health inpatient care for adults with learning disability, and the second line around the mental health inpatient care for autistic adults. Now, although we're sent these figures that we get asked nationally, as every ICB does, to put a plan in on those 2 lines. But then how we get judged through the year is the combined number of those. So that's where we've presented them individually as the plan, but then we've got that combined where it says 53 across both. That's the kind of nationally where they'd like us to get to when you aggregate those. And that's where Deborah mentioned during the bit she was discussing that we're currently at a position of 71 as that combined, so that is an area where there's work to do. Equally,
okay, I appreciate that, because that was the answer I was expecting in terms of the national targets, that you're aligning your information to national targets. We locally, through the ICB board, and when we've got statistical information from our own mental illness teams, our community mental illness teams, the need out in the communities to support people with either or some of those issues being diagnosed locally by their GPs. Is that information not fed into anybody from the GPs themselves in terms of their role within the first stage of accessing somebody being able to get an appointment to speak to them about the mental illness or their fears or whatever? That then is referred on to the mental illness team for another assessment, and it could be the community teams themselves will work with them in the community. That does not need to say, and I appreciate what you're saying, we need to consider this as one of the local issues, either through the ICB board or our own scrutinies, which we do, that there are issues around all of these in our community at the moment. But yet it makes this picture look that we've got 71 across the whole patch, which for the whole of West Yorkshire in statistics going forward is not right. It's not true. It's the way the information is gathered I'm trying to get to the bottom of, which gives this picture that across the whole of West Yorkshire, in those categories, that we locally, within our patches and within West Yorkshire, know that we have problems, that this makes this, because we're equating it to some target that isn't there, that locally we don't have any targets ourselves that we can say, this is happening in that trust, this is happening in this trust. We're all at this point looking at a commissioner matrix here that makes it look as if none of it exists, because there's not a national target. Now, the picture going back on this, Chairman, through your good self, is how do we follow through this, through the ICB and through our own local community health and scrutiny committees, with reports back from our mental illness trusts?
Yes.
Because we need to follow this through either locally to see what the picture is and make sure that the services are out there to support them. Because I know, having dealt with some cases, and I've worked a long time along the mental illness field and commissioners, that this is a national picture that makes our district look very good, when in fact we know locally the suicide rates are up.
Yes.
It's worrying. It's worrying, Chair.
I think the thing is, these figures relate purely to inpatient care for people with mental health, autism, and learning disabilities, not to the vast majority of people with those conditions who are being looked after in the community. So I do think that there may be a role for a West Yorkshire scrutiny of this, but a lot of it does come down to the individual area scrutiny board, local authority scrutiny boards, I would suggest, but you may feel differently. I'm very conscious that time is pressing on, and we still have another agenda item. So I would like to just bring in Councillor Timbers, if I may.
Just a very quick question. Excuse me, because this is my first meeting. Do you report on the figures for restraint in mental health units? I mean, you'll have those figures because you're required to have them under the Mental Health Use of Force Act 2018, and you should also be able to break them down by protected characteristic. Do you have those figures? Because they're actually quite useful to know what's going on in terms of restraint in mental health units, about the culture and the success of those units. And it would be good to have those figures, and also to know if there's any disproportionality in its use.
Yes. I
Right.
I doubt if you have those to your fingertips, but if those could be provided to the committee when you can, as soon as you can put them before us, you know, within the next few weeks, that would be great. Would that suffice, Councillor Timbers?
Yeah, that would be excellent, Councillor Hutchinson. Thank you.
Okay.
Thank you.
Okay.
Just to make the point that it's a really good way also of working out not just the quantitative metrics, but the qualitative nature of the service as well. It gives you some guide to that.
Ian?
Yeah, I mean, just to make a wider point, Chair, if I can, we've shared the data that we were asked to develop plans for the 25-26 planning process, and that's what we've done. Clearly, there are hundreds of metrics that are reported and recorded through organisations in West Yorkshire, through the board in West Yorkshire, through our other governance arrangements. And, you know, we've had conversations here on suicide prevention, as you know, broader conversations on mental health and public health. We're happy to do so. I guess the trouble with a kind of an item like this is that it can cover the whole breadth of, you know, everything the NHS does. And, you know, like you say, we've taken an hour and 40 on this item already. So I'd be really keen to work with you and Councillor Smage going forward about how we get the right chunking of the items up so that we can give, you know, each item the appropriate consideration.
I would ask members if there are specific metrics that you would like to come back to us. If you could let me know, and I'll take that forward with Ian to try and get that information to you so that you can inform both local and ICB-wide scrutiny. So can we just rapidly, Deborah, finish off through this item? Yeah.
Thank you, Count. Thank you, Chair. We've just got one more slide. We'll just do the last slide, which is about the ambulance service. So Yorkshire Ambulance Service, West Yorkshire is the lead commissioner for the ambulance service. So that's for North and South Yorkshire. Just a couple of headlines within this. We have seen demand for the ambulance service, the demand go up 3.6% over the last year. Obviously, that has been factored into our plans. We are maintaining the number of hours on the road. Obviously, that comes with some increases in staff. Within the ambulance service, there will always be a level of reliance on overtime and bank staff, just to the nature and the seasonality of the services. So that's one point to recognise. But some really good news from the ambulance service. Over the last year, we've increased the number of clinicians that are working within our control centres from 85 to 112. So that's obviously a really key in triaging those calls and being able to dispatch the most appropriate service. Our category 2 targets, we were last year just tracking above the target of 30 minutes, 31.56, and we are looking this year to achieve 28.48. And I think if my knowledge over the last couple of days of working in the System Coordination Centre, and Dave will correct me if I'm wrong, I think we're tracking at the moment at around 21 to 24 minutes for a category 2 response. But obviously we are in the summer months and we do see most significant challenges within the winter months. Some actions that are being taken by YAS and working with all the ICBs across Yorkshire are to look at variances in conveyance rates across places and across areas within those places. And that's a piece of work that's being led by NHS England and West Yorkshire through the various forums and collective conversations with YAS. and that will help us start to improve our hear, see and treat. So that is where we get the telephone call, we go out to see the patient and we're able to treat them or refer them to alternative services. So lots of work going on within the Ambulance Trust, but across the ICBs as well, to try and support and improve patient experience and critically improve those response times for the Ambulance Trust. That's where I'll end the presentation. So any questions, Chair, around the Ambulance Trust? I'll see if I can answer them.
Councillor Nicholl?
Yeah, I'm just wondering, where does patient transport fit in?
Patient transport, we do put it within the plans, but it is a separate level of the plans, and there's lots of work going on around patient transport over the last year, and I know that continues to try and improve those services as well, but it's slightly different within the operational plan. But if you're interested, obviously we can provide some details of the commissioning intentions for the patient transport service for 25-26.
Yeah, it's just an observation. Over the last 12 months, I've had cause to use Dewsbury Hospital a lot, and I do see a lot of patient transport ambulances parked up at all times of the day.
Are they patient ambulances or transport ambulances?
Well, I'm not sure.
Yeah.
There's a lot of vehicles parked up.
Dewsbury Hospital's quite busy. It's quite busy with ambulances, but there's quite a lot of outpatient services there. So you will see, if they are transport PTS vehicles, then obviously you will see quite a lot of them to and fro from all hospitals as well.
Okay.
Just to give some context, the national standard for category 2 response, that's for people having strokes and heart attacks and serious problems like that, is 18 minutes, but that hasn't been achieved for 5 years according to the 10-year plan. So we're still quite a long way off that, even with the improvements that have been achieved so far. So still work to go. I think you have shared with us some of the other areas of risks and mitigation, but unless anyone has a burning question about those, I would like to move on to the next agenda item. But if members do have any particular questions on those, this is something that we will be coming back to very shortly, because it is such a moving target, and until September at the earliest, there's a limit to what the operational planning, the detail of the operational planning that the ICB is able to share to us, because there's some very sensitive decisions to make, as well as we haven't had and there's continuing releases from the Department of Health as to where we're going. So, but if there are any urgent questions just now, and then I would make a request that the ICB comes back to us with a more detailed summary when they're able to tell us in greater detail how they're managing the challenges that they're faced with. I can't see any hands up. So thank you very much, Ian, Adrian, Deborah, and Dave for your input today. And hopefully Yolanda's made a list of the items of information that we'd be grateful if you could share with us. And if members would let me know if there's any other specific metrics that you would like provided to us, just drop me a line. Okay, so if we can move on to the discussion of the briefing document that we've received from the West Yorkshire Association of Acute Trusts.
Morning, Councillor Hutchinson.
Good morning.
Good morning.
Well, welcome, Lucy.
Nice to see you again. And morning to everybody that I've not met before. My name's Lucy Cole. I'm the director of the West Yorkshire Association of Acute Trusts. So I'm conscious of time, and you've got a briefing note, so I'll just pull out some of the key points if that's okay, and we can get straight into conversation if that's helpful.
Yeah,
so probably what's helpful, particularly for members newer to this committee, is the West Yorkshire Association of Acute Trusts, or WYAT, is effectively a provider collaborative. It's not a standalone organisation. It is those 6 member trusts that you find outlined in the paper working together on a number of areas, which is focused around how can we improve the outcomes for the population across West Yorkshire and Harrogate. And that might be through working together through networks, sharing best practice, implementing new ways of working, or it might be some do-once schemes, which I'll talk to you a little bit about. So I think just an important note to note around governance and how WYAT works. So it's a committee in common model, which means there is a committee made up of the chief executives and chairs of the 6 organisations, which meets on a quarterly basis. That is formally a committee of each of those 6 trusts. And therefore the kind of statutory decision making remains with those trust boards, and we do all our reporting through those trust boards. Very similarly, obviously we do reporting through Ian and colleagues in the ICB. And important to note that what in practice that means is we can take decisions in the organisations whereby that doesn't influence the way patients access services, but if there is a recommendation in that respect, obviously the ICB remains the commissioner and therefore the decision-making authority, obviously in conjunction with overview and scrutiny. So section 4 just gives you an overview of the key areas that we're focused on at the moment, and that's in the context of our 5-year strategy, which we published last year in May 2024. That is available online if people are interested, and obviously that's focused around 6 core areas, which I expect everybody would be likely to see in similar strategies, whether at an organisation or a collective level. So the areas we're working on at the moment for people's awareness, so pharmacy aseptics, so we're part of a national, what's known as a Pathfinder programme, and we are building a kind of aseptics manufacturing facility, and this means we can prepare large quantities of pre-prepared medicines which will serve all of our hospitals. We'll continue to have our aseptic units within the hospitals for people that are familiar with those, and they're concentrating on preparing medication that is very patient specific, like chemotherapy. This allows us to prepare some of those products that we either need to buy in from the commercial sector or are often prepared by nursing staff on the wards. So the aim here is to reduce reliance on the commercial sector, which can be expensive and also fragile in its supply, but equally free up nursing time to care by preparing these products in an aseptic environment. We're already supplying some of that at the moment, and that's on a scale-up plan over the sort of next 12 to 18 months, and we expect that unit to fully open next year once we've had approval from the MHRA, which is the regulatory authority that oversees medications and devices. Pathology, people might be aware of some of the work we've done in pathology previously, and this was off the back of 2 reports done by Lord Carter in 2008 and 2016. And this is focused around standardisation and where we can consolidate some of our routine testing. Digital has been a big aspect of that, so we're rolling out a single, what's known as a laboratory information management system that allows us to do some of that consolidation of testing and make sure that we can share the kind of digital aspects of that testing and make sure the results get back to the requesting clinician. Equally, we've rolled out some software which means that we can see results requested in other hospitals across all our trusts. So if you're a clinician working in one hospital, you can see patient results from tests ordered in another, which traditionally we've not been able to do in the past, which is great because that means we're reducing duplicate testing and repeat asking patients a number of questions that we don't need to. And pathology is heavily automated for people that are familiar with it. So we've been deploying some new state-of-the-art equipment, particularly in the new laboratory at St James's, which will become a hub for both blood sciences and microbiology testing in the future, and will continue to act as a specialist reference centre for the region. In imaging, again, very technically focused, and people are probably aware that radiologists and reporting radiographers now view all of those images that captured, whether that's through scans like CT, MRIs, X-rays, now on a high-resolution computer screen. We've deployed over 250 home working stations, which has been really well received by clinicians in terms of creating some work-life balance, but also there's been work to ensure we can do cross-site reporting. So if we've got a patient waiting for a report and we might have a staff shortage in one hospital, that means it can be reported by a clinician in another, and therefore speed up diagnosis and treatment times. Equally, we've been one of the areas nationally selected to deploy artificial intelligence in chest X-ray, and this is used as a decision support tool in terms of how we prioritise reporting of some of those chest X-rays, and that's part of a national evaluation with University College London. Planned care, there's been a lot of conversation about performance this morning, and particularly in terms of referral to treatment times. So as you would expect, huge amount of work happening around planned care on how we can improve our productivity. Lots of use of benchmarking information, and we have a large number of clinical networks set up that are specifically looking at how to reduce any unwarranted variation between trusts in that specialty, but also where we can use collaborative working to support seeing patients faster. And that might be around things like use of surgical hubs, which we now have a number of across West Yorkshire, and equally how we use our community diagnostic centres. And then finally on procurement, this isn't just a Wyatt initiative. So as Adrian mentioned, we've got 10 big NHS providers across West Yorkshire. So that's all 10 of those providers working together on how we procure goods and services outside of the NHS. Last year, that provided an additional £2.3 million of savings on top of the procurement savings delivered in each of the organisations. And by working together more closely, it's anticipated that that will be significantly more over the coming years. So, and this is about using our collective buying power in a more formalised way that will allow us to align contracts and get best value from organisations outside the NHS. Finally, we note we also host the stroke network, and there's been a lot of improvement work happening through that, and most recently launching the All Things Stroke website, which is accessible to patients that have had, whether themselves or their families and carers have felt the impact of a stroke in their family. Just a quick point, I think, to make just about looking forward. Obviously, the 10-year health plan is the major area that we're all responding to. Obviously, that focuses on those three main shifts that I think have been well trailed by the government in terms of hospital to community, treatment to prevention, and analogue to digital. But it also has a really significant focus on our return to constitutional standards and financial sustainability, both of which you've had quite detailed conversation about this morning. So in response to that, we're just looking across the trusts in terms of how we provide some of those services at a place level, working with our partners from primary care, community services, voluntary sector, mental health services, in that provision of integrated neighbourhood healthcare, which Ian mentioned earlier. But also the work we need to continue to do across secondary care, thinking about how we use some of those assets I've mentioned, like community diagnostic centres, but also thinking about how we need to continue to plan and deliver our services in the future. And needless to say, obviously, a lot of change in NHS structures, which we're working with the ICB on in terms of it becoming more focused as a strategic commissioner and how providers work together to deliver those outcomes as prescribed by the ICB.
Okay, thank you very much. I mean, I think that point you make about the change in the way in which services are commissioned will mean that Wyatt does have an increased importance in terms of the designing and shaping of services across West Yorkshire. So I would like members to give some thought as to the best way in which we can fulfil our scrutiny role in terms of looking at what Wyatt is doing as the year goes on. So maybe some thought there. Can I just mention the 10-year plan, which you're focusing on, has very little to say about emergency care. But we know that that is one of the principal things that people require of the NHS for peace of mind, that when they need emergency care, it's there promptly and safely, as well as safe as possible for them. And yet there's no mention of emergency care in this briefing note. Why is that?
So primarily Councillor Hutchinson, and Ian, feel free to come in on this. I think obviously WIAT is the sort of culmination of the things that those organisations do together and where they can make the most impact by working together. I think in the urgent and emergency care kind of arena, the most impact really is about working together with partners at place. So it's as much about what happens in primary care, GP out of hours, community services, rather than kind of the culmination of hospitals working together. Obviously, we put diverts in place where we feel that's appropriate if with particular organisations overwhelmed in its emergency department. But largely the focus, I think, on those pathways is at a place level rather than a kind of WIAT level. Having said that, obviously there is a huge opportunity in terms of sharing best practice. So we do have those groups in place at a clinical and operational level, and they look specifically at things like deploying I think colleague earlier, Councillor Lay, mentioned same-day emergency care. So everybody's deployed SDEX in some way, shape or form. So there's a lot of work happening in terms of best practice of how that's done, who's having the most impact in how that delivery model works and how we can roll out some of that learning across the organisations. But I do think that heavy focus really needs to be at a pathway level, at a place rather than a West Yorkshire focus.
Okay, as I say, it's just because it features very little in the 10-year plan, although there is a separate urgent and emergency care plan that was published in June. So it's important that we don't lose sight of that. Councillor Rhodes, you're on mute.
I've been reading this report intently. First of all, Lucy, can I say many thanks for a report that is concise but yet so informative that anybody picking up this report has been given an insight and understanding of what is happening out there and what you're actually doing in WIAT. I think the information is so good that, as you've just mentioned, ahead of my coming in, this is really important at place at the moment. And I am going to suggest when I have my next briefing and timetabling for meetings, that I'm going to get this report circulated to my own scrutiny committee in Wakefield. I think the information in it is valuable for every scrutiny committee if they want to use it and be informed. But I think it's an example of good practice of a report, content, and the reasoning in it why things are done the way they are. So with that, Lucy, I won't say any more, but I think, Chairman, it's a very important report, and the detailed information, it has to be commended to yourself and others involved.
Thank you very much, Councillor Rhodes. Do we have any thoughts as to how to effectively scrutinise the ongoing work of WIAT, aside from the local individual trust level? I mean, I do have questions myself as to how well the centralisation of laboratory services is actually working out, whether it's delivering the savings that Lord Carter was suggesting that it would save. Centralising microbiology does involve transporting quite delicate samples from various hospitals where the patient is to a central laboratory, and for microbiology that can lead to deterioration of those samples and the diagnostic yield. So I was just wondering, in practice, is it working out as swimmingly as was originally proposed by Lord Carter and delivering what was required? So
So we do already have some examples of that, Councillor Hutchinson, that have been running for a while, whereby there has been some centralisation across laboratories. We're obviously in the process of looking at that now in terms of the new build that's just happened at St James's. You're absolutely right in terms of the transport factor being really important and preservation of cold chain and all of those things, which are obviously heavily regulated. I think the balance here is about, at the moment, a lot of our microbiology services work between 9 and 5. The new laboratory, once all that's centralised, will be at significantly extended hours. So we've already got a situation at the moment, should samples come in after a certain point, they're not being processed to the following day. So there is that counterbalance of actually we're getting quicker turnaround times for patients, which is obviously a great thing. And the way in which we've managed to equip the new laboratory means there is much more significant automation, which again means less touch time, quicker turnaround times for patients. And that's some of the most advanced technology now that's being used in Europe. So absolutely, there are risks in terms of, as you described, the kind of movement of samples, which I think obviously will be mitigated in terms of how heavily that's regulated. But there are kind of opposing benefits to centralising that, which is what Lord Carter was describing. I would say that was done quite a while ago now. So 2016 was quite a while ago. So obviously what we've done is to assess what we believe the benefits are in West Yorkshire of doing that. And that's what we'll monitor ourselves against going forward. But quite happy to come and give you an update on that as we progress that further.
And can I just ask where this main aseptics hub is actually located?
So it is. So it's on a kind of new industrial estate, which is sort of M621, M62. So it's well located in terms of motorway access. It's obviously not an official NHS site because of the types of products it is producing. So we don't give people the exact location, but it's well serviced in terms of motorway access to be able to access all the organisations.
Okay, thanks. Thanks. Okay, so unless anyone has any final burning questions, I think we'll call it a day there. And thank you very much, Lucy, for your report and your presentation. And thank you, members, for your participation. So, as I say, any further requests, if they come through to myself or Councillor Smage for any other information that you may find valuable, please let us know.
Thank you, Chair.
Thanks, everyone. Bye-bye.
Thank you. Bye, everybody. Bye.